we should just go ahead and get started. We're expecting a few more, so sorry, especially Mark, as people come in, if it makes you feel thrown off, but alas, that's just the deal. So welcome everyone. I'm Kira Degree-Kennedy. I'm the director of CoThrive and really thrilled to be here with you all this morning. We have just a couple announcements at the top here, and then I'll introduce our guest speaker who I'm thrilled to have with us today. We are revisiting our meeting structure and cadence in 2025. So the first Friday of 2025, when we would normally have a meeting in January, we're not going to have. It is right after the holidays, so we're gonna skip that meeting and then start back up in February. Depending on a couple of different funding things that are hopefully going to be coming through, we'll likely, for those of you who have been around this coalition for a long time, we'll likely have some of the work groups start happening again as well, but that's TBD. So expect to not have a meeting in January, but for us to get back together in February. If you haven't had a chance to check out our new website, Sarah is going to share those links in the chat. We'd love to hear what you think. And if you're not getting the CoThrive newsletter, feel free to sign up. Sarah will also drop the sign up in the chat today. And that will give you the recordings from all of the past meetings and let you know what's going on going forward. So today I am just so excited to introduce you guys to Mark Smith. I'll read his bio in a moment, but also just listen to his beautiful voice. And no matter what he says, I'm like, I'll do whatever you say because it's just so beautiful and charming. He is the Director of Public Service Reform at Gateshead Council and the Senior Responsible Officer for Changing Futures Northumbria. His focus is on moving from a standardized one-size-all-fits-few approach to a bespoke by default model. His work on holistically supporting those with debt, who are homeless, who are substance dependent, and who are regularly offending or who are generally going through tough times, goes hand in hand with developing a more flexible and purpose-driven workforce. He's previously worked in policing, health, and charity sector to develop his approach to saving money by doing the right thing. So he's joining us all the way from the United Kingdom today. He has been a partner, a thought partner, and a real leader in systems change in our worlds. And so I'm just thrilled to introduce all of you to him. As a reminder, we are recording today's event and we'll be sharing this out afterwards. So if you've got folks from your organizations that have not joined today, feel free to share this recording afterwards. Final note, I have a sick kid home today, so I'm going to be in chaos mode over here. So I'm going to hand off the kind of meeting and Q&A after party to Sarah, so that you don't have to hear the Grinch Who Stole Christmas in the background. So thank you all so much for joining us today. And Mark, the floor is yours.
Thank you, Karen. Hi, everyone. I'll just dive straight in, shall I, after that really generous introduction. I'm really self-conscious about my voice now. It's a very wet and cold night over here. It's 5 p.m. It's very dark, and if a storm gets really bad in the UK, they name it. And with each storm, they name it. It's always a name, and it alternates male, female, and it goes up a letter in the alphabet. So we're on Storm Dara at the moment, the fourth grim storm of the season, and it's horrible out there. So I'm very grateful that I'm not out there, that I'm in here. Okay, I'm going to see if I can share this. Okay, can I have a nod if people can see those slides?
Yep, we got it.
Tremendous, thank you. Okay, so I'm going to speak a bit today about what we call the Liberated Method and something that we refer to as relational public services. The image I've chosen here is quite important because one of the things that years of public service reform work in the UK and worldwide actually has kind of assumed, sometimes explicitly, sometimes passively, is that if we sort the system out, it will be the tide that lifts all boats. You know, we can sort the system out, do lots of work on the system, and everybody will benefit. And you can see there that the tide hasn't lifted that boat because there are some people where all this change leaves behind. And I've always been curious as to why. So we decided not to, in my work as public service reform director, I decided to stop trying to reform services. What I wanted to do instead is because people don't want services. If you start with services, you end up with them. What people really need are relationships. They need to be understood. And I don't just mean in a woolly sense, I mean in a really specific, gnarly, everyday, messy sense. And if public services don't understand that, they won't necessarily be very effective. And they won't know when they start and stop and relationships start and stop. And this dynamic is something that we've explored for quite some years now. So I'm going to show you a little bit about that. Okay, let's see if this works. Here we go. So just a little bit of history. We've been working on this for the last 6, 7 years. We started off by using debt as a signal, not as a signal to go and tackle debt. So I work for a council, a local authority in the UK, and one of the things that we have to do, amongst many, many other things, is collect council tax. So part of the local taxation system in the UK is that every household pays an amount of tax to the local council. This is in addition to tax to the government, and that is broadly calculated on how much your property is worth, whether you own it or not. And if people fail to pay that, we write nasty letters to them. And if they fail to take notice, we send a bailiff around to collect belongings that are commensurate with the value of the debt. But that is not what we ought to be doing. That's a signal. And we did some research and we noticed that the system is predicated on an assumption that people won't pay. But only 4% of the people that had a significant debt were with the won't pays. 96% were the can't pays. But we were paying zero attention to this, chasing the money. And what it was happening is it was driving demand up into our other services, into social care and into other departments, other organisations such as policing, and other social organisations. And we, as humans, we knew this, but as a system, you wouldn't think we did. So we did a piece of work there, which we took 40 families that were due a visit from the bailiff. They were in advanced stages of this recovery process. And it will come as no surprise to anybody that interacts with other human beings, that for all of those families, debt was not the main issue. It was just the issue that was surfacing to one particular bit of local public service. And so we set a team up, and we basically said to this team, I wanted to experiment with relational public services with the idea that we meet the person or the family where they are. So we got people that were angry, that were fed up of making phone calls about this stuff to try and chase for money. And we gave them a small budget and 6 months and a list of 40 families and said, just give them a call and say hi and ask them how things are going. Say, we've noticed you've got quite a big debt. Don't worry, we're not chasing you for it. We just wondered how things were, and take it from there. And their job was to adhere to what at the time were just two rules, which were don't break the law and don't do any harm. And the principles that we gave them were understand people, don't assess them. So just meet them where they are and just do whatever comes naturally. And do it as a relationship, and we'll see what happens. And of those 40 families, 32 of them who had been bouncing around the system with all sorts of issues around social care, children that required support and protection, 32 of them, big turnarounds, four of them, not so much, and the other four wouldn't engage. And that was simply by starting from a different premise with a relatively generalist workforce and some money, not much, but some money. And I'll go into some more details about that as we develop this presentation. That work really taught us that bespoke by default rather than standardization was a much better route into trying to help people that were chronically consuming large amounts of public resources and services, but their lives weren't improving. So we widened the work into homelessness and into some area-based work. And more recently, we ran a big program around Changing Futures Northumbria, which got some external money from the government, where we chose 4 different sites, but we deployed the similar method in all 4. So those 4 sites were the emergency room at a hospital. We were really interested in the people that were showing up very, very frequently. Women's Refuge in Newcastle, which is across the river from Gateshead. Women in particular that were fleeing from domestic violence situations. We wanted to support people that were struggling with alcohol, and also people that were homeless in 4 different parts of the northeast region in England, so beyond the Gateshead area where I work. And we were told by the government that people had to have 3 out of 5 particular things wrong with them. And we decided to ignore that and just go to where people were struggling and talk to whoever wanted to be spoken to. And we took it from there. And what happened was remarkable, in as much as not just the turnarounds that we saw, but what we learned about public services, what we learned about people and communities. So, very boring mechanistic diagram. I'm going to start with it. One of the things we noticed when we spoke to people that were bouncing around, we asked them what life had been like for them when they'd interacted with public services. And it sounded like a really complicated story, but it boiled down pretty much to 6 boxes and 3 loops. And this was really common. So the first loop is no, we'll assess you against some criteria, and if you're not for here, go somewhere else. The second, so that's the first little loop on the left. The second loop, if you get in, oh yeah, you want to, you're eligible for our, we've assessed, we'll then assess you. And an assessment is not the same as understanding somebody. So an assessment asks a slightly subversive question, I think, which is, from the point of view of a public service provider, how much of what we do can we do to you? Or how much of what we have can we give to you? As opposed to, what does a good life for you look like? How might we help you with that? Who might be able to help you with that? What's your role in that? These questions weren't being asked. How much of what I do can I do to you? And if we can do something, we will. And if we can't, we'll refer you on to somebody, or we'll do something and then refer you on because we know that we're interested in this bit of your problem. And then that loops back out and round. So there's loops within the blue box around assess, do, refer. And when the system's finished with you, you've been interacted with, but not necessarily helped, and you loop back round and you come in again. That was a depressingly repeatable and predictable scenario. And from the early sample that we took, individuals were rotating around the system between 5 and 55 times in that blue box. And I think between 1 and 33 times, it's not on this slide, around a big one. And this was the same whether or not you had a debt issue, a homelessness issue, it was reablement after a stay in hospital, or antisocial behaviour. This is the public service design. If you look at it from the point of view of people interacting with the system, no structure chart will ever show you this. This is what it's actually like. And when we looked at the activities, the interactions, because people gave us consent to dig their data, and we dug their interaction data, a quarter of it was recognizable as something that might help you. 3/4 of it was the system feeding itself, getting permission from a higher power, but feeding a performance indicator, justifying, or sometimes slightly cooking the PIs to falsely justify getting funding. A noble intent with slightly ropey methods, because at the end of the day, people want to help people and they'll do what they can. So we found lots of different IT systems, lots of different documentation, lots of different interactions, around about 62 people, if you like, touching that flow of work. And all of the people that we looked at, their stability was either the same or it got worse, and their dependence on the system was the same or it went up. So it wasn't working. So I'm going to introduce you to Brian now. So Brian was somebody that we helped in Changing Futures, and Brian told us his story. So Brian was a train driver, and one day, and he was married, he had a family, stable life, barely interacted with the system, if you like. And a slightly sort of trigger warning here, because it's a bit of a horrible story. Sadly, somebody jumped out in front of Brian's train one day as he was driving it and was killed. And it affected Brian very, very profoundly, to the point where he took to alcohol and his life fell apart. He lost his family, he lost his home, lost his job, his health. And he spent 14 years bouncing around the system and ended up homeless in Gateshead. We asked him to tell us his story, and he did. And from that, we dug up his data from 8 different organizations, and we plotted all of these interactions in what we call a swim lane diagram. You'll see on this one, it says A&E. That's British for the ER, the emergency. We call it accident and emergency. So he was turning up at the emergency room an average 1.5 times a day. He was the single most frequent attender to the local emergency room. But that's not, so all of these orange boxes are attendances, or sometimes, or an ambulance call out or something like that. and none of the slides you're about to see overlap. Okay, so this is a bit of Brian's story. Here's another bit. I mean, imagine in our lives, one of those boxes would be a story to tell or something we'd remember. It gets a bit mind-boggling with him. There's some more. This is still more health presentation. This is over a 14-year period. The lines are quite important because they connect incidences, because as we know, consequence and cause is a very layered thing. So we can see presentations to A&E, we can see a heart attack, we can see some inpatient episodes at the hospital. And here we have some mental health assessment, lots of assessments, very little understanding, lots of assessments. There's a section 136 detention there, so that's a detention related to mental health. We can see more. And here we have the criminal justice part. So 3 months prison sentence at Durham Prison. Lots of arrests, lots of conveyance into custody, lots of custody. I think you get the gist. And there's more. And this is the same guy. This is the same guy. None of these overlap. And Brian is not super unusual. There is a cohort of people like him in every town in the UK and the world, possibly. But this is what the system kept doing. In and out, in and out, in and these are those 3 loops writ large right across his life. And here we have more and more and more. And when you zoom out, it kind of looks a bit like this. So everything on the left, that clump on the left, the y-axis is time, but it's distorted. So there's a compression on the left, which is 14 years of activity, and it's bunched. So the top bunch that you can see is the health system. The next bunch down is the criminal justice system. The next bunch down is the social care system. The next bunch down is the probation. Then we have mental health. Then we have, I forgot what the other one is, but it's different elements of public service. What's critical is the blue boxes along the top represents a year. The crunched up bit on the left the blue boxes going across to the right are a year, the most recent year. And the scrunched up timeline on the left is 14 years. But we've done this deliberately just to get all the information on the page. Where do you think we got involved? So the really important thing to bear in mind about this diagram is the white space on the right. You'll notice that Brian did need services. There are some orange boxes there on the right after we got involved. It's not like services were poor. It's not like they were not doing what they were designed to do, but they were just being used transactionally. But we needed a relational approach that has context. The stuff across the top is what we did, and the reason it's across the top is because it doesn't fit in the system. Brian needed a relationship. He needed lots of small things that were big things. He needed someone to recognize that he lacked self-confidence because of how his teeth looked, that he didn't have any food, that he was nervous about going to an appointment so somebody would go with him, that he loved poetry and he would like some materials to write it. He would like a place to read it out. And he wanted somewhere to live, something to do, and someone to love. And no assessment will ever tell you that. But we know this. Of course we do. So how did this happen? Well, just to do some of the analysis. This was beforehand, his consumption. So I've just taken off something at the top because it's his real name. His consumption went up year on year. So it's not as if we weren't warned. This is the number of incidences year on year. And this is kind of what happened to him. So when he was presenting to those multiple services, he was being navigated plausibly and well-intentioned by lots of great public servants. So if you are, let's say you have 2 issues, a debt issue and a health issue, and you want to see a specialist about that, what you can do is you can either present to each of them, the green lines are presentations, or you can present to one and be referred to the other. So the referrals are the little dotted lines. And each time you do that, you have to get through some eligibility criteria, which means you're screened and assessed and you have to tell your story. And you try to tell the right one. This takes an assumption that the answer to your context is an assimilation of those specialisms. And if you've got many issues going on, you're going to have to try and navigate all of that. There isn't a poetry specialist in the system, but I'll tell you what, didn't half help him. So navigation does not necessarily navigate us to where we want to go. It navigates us around what we have. And that is because these specialisms do a lot of great work. They do solve problems, but they're not great at solving context. Something's missing. What we did instead was we didn't do any assessments. We sought to understand. We paired each citizen up with a caseworker, a generalist, low caseload caseworker. Half of our casework army, if you like, have lived experience of addiction and recovery. Half of them have a professional background, but all of them know that navigation isn't enough. And they will work with an individual based on what matters to them. And initially, what matters to them is what matters to them now. So there's no food, I've got no money, I'm homeless. So we'll be very pragmatic and provide things. But as it goes on, the what matters ultimately kicks in, and people start to realize that their agency is the answer to this, not our services. But that takes a relationship to pull out. So while we're attending to the non-specialist bespoke support within context, we're pulling on specialisms, but with context. I'm not belittling specialism. I'm just saying it needs to have context to really enrich it. And if you're transacting, it doesn't happen. Those orange boxes are proof. So we adopted an approach where we wouldn't refer, we would pull, and specialists would come to the relationship between the caseworker and the citizen, and they would do work together. Well, was it effective? You saw that chart, very much so. And what, sorry, so what we did in equipping those caseworkers is we gave them the rules that we talked about before, but we also gave them some principles. I'm going to walk you through them. And lies at the heart of what we call the Liberated Method. So this is turning lives around that have not been turned around very successfully by the system. And the rules are that the key about this slide is that a combination of rules and principles is really important for relational public service. The rules give you the rigor and consistency you need and the protection. The principles allow you to absorb variety, and nothing varies like people. But if we try to do pathways, procedures, and protocols, a purely rule-based system which has heaps of accountability in it won't work. So you spend your time essentially justifying failure rather than learning and iterating. So let me walk you through the rules. The rules are straightforward. Stay legal, don't do any harm. And then we added a third rule because key to the program is learning. And what we learned was that some people were not activating their agency. They just wanted to take from the program. And those people tended to not have agreed a clear purpose of the relationship with the caseworker. Whereas the ones that went through were brilliant and they were able to do that. So we added a third rule. The rules are absolutely sacrosanct. There is no negotiation. You stick to those rules. Principles, huge amount of wiggle room here. So we understand and not assess. The scope of the work is unlimited. It's set by the relationship between the citizen and the caseworker. So that's how poetry, dog grooming, carpentry, all sorts of weird and wonderful things find their way into the discourse, not tokenistically, but contextually. The decisions about the work are made in the work. They're not made in the boardroom. They're not made by me. My job is to clear the runway so they can fly the plane. It's not to stand in a cockpit and tell them what to do. So if the decisions are made in the work, great things happen. And if they need advice and support, they pull for it. They pull a specialist, or they'll pull me, or they'll pull anybody. But it's up to them to locate the decisions in the work. The idea of referral we're trying to get away from, but practically we know sometimes you have to refer, which is why it's a principle, not a rule. But if we do refer, we still hold the case. We go with the referral, but ideally what we want to do is pull for help. And the final thing is that we don't have any arbitrary time limits on this. The reason this found its way in as a principle is because certainly in children's services, there are specific timescales by which we have to have achieved an understanding such that we can make decisions. But it can take one child 5 days to sort of feel understood. It might take another child 5 months. And the ones where it was more complicated were being let down by a system with an arbitrary target in it, and we weren't having any of that. So coming back to this story, on the left, all of those interactions, 3,500 of them nearly, and it cost, if you add it up using unit costs, that one individual, £2 million minimum. So what's that? Just over $2 million. Just him, and to no obvious benefit. if you look at what happened when we got involved, so Changing Futures Northumbria got involved in 2022, we could see the cost bouncing around a yearly cost. So it was peaking at just under £500,000. In the first year, it went down quite a lot, and in the second year, it virtually vanished because he was sober, he was in a community, he was working, he had a tenancy which he was able to maintain, and he's still vulnerable because that's the recovery path. He's working hard to maintain an equilibrium, but he has an equilibrium, and that's because he was understood and he was stuck with people. He relapsed a couple of times and we didn't budge an inch. Infinite second chances, understand, build a relationship, lots of bespoke work and some specialist input. And that's pretty much what we saw across the cohort by and large. This is a different person. We got involved at the top where the red square is. You can see all of the service interactions on the left. You can see all the blue interactions on the right, and a much reduced amount of service input on the right as well, because this guy needed some services, but he needed a lot of things that a service would never do. And so what you see here is the navigation achieves this. The black dots in the middle, the non-specialist bespoke stuff is that, and the pull for specialists is all the orange stuff. So the stuff on the right is more like what happens if you understand somebody and you work with them and it reduces cost. But it is difficult work because by the blue stuff is all the really everyday, non-technical, but quite harrowing at times work with people that have got a lot going on. This is for the very acute end of contexts. So we asked ourselves, well, what's going on here? What is it that the caseworkers are achieving? And I'm looking at this now, I'm switching perspective slightly as a director of public services and asking myself, what do I need to design organisationally to make this work? What am I going to say to partners, to police, to health, to whomever? And what was apparent is that services are designed to provide extrinsic input. We're here to do stuff to you, with you, we'll give you stuff. And that's the beginning and the middle and the end of it. So the extent to which it works depends on a bunch of outcomes which are predetermined, and it's a fiction. What we actually saw is that as the extrinsic support, which was valid at the start when somebody's got nothing and they just need things, if you think of each person's as a cross section of the green and blue here, they move to the right. Starts off all extrinsic. We're just going to help you out of this hole. We'll get in the hole and we'll help you climb out. But what tends to happen as they stabilize is they start to say stuff about what matters long term. And that intrinsic community or self-awareness starts to take over and it brings that internal drive. And then our caseworkers look for that and it starts to guide the work and they end up finding themselves, the ratio between green and blue starts to change till such point that we don't really need them at all. They don't need us at all. It's just a watching brief. If you know that that's the pattern, you design the blue stuff differently. It's not that the blue stuff we have now, if it just does the green stuff and we don't let it, it won't. We have to design extrinsic support because we know intrinsic support is the answer. The nearest analogy I can find is a vaccine. A vaccine introduces something to you which allows your immune system to kick in and do the job. This is a bit like that. We're introducing some pragmatic stuff which kickstarts your agency, and that's what does it. And the recovery community are very strong on this. They're very keen that support and community is what really gets people over the line. But at first, you just need some pragmatic support. So we had a number of different case studies that came in at different levels of acuity, including Robert, who didn't really need us at all. He just needed some transactions. He needed some advice on his tax, but he was so stressed about it that he thought he was in a real pickle. And when we helped him with that, he was like, oh, do you know what? I'm fine. And we never saw him again. Whereas Brian needed a massive amount of extrinsic and people are either in crisis or maybe they're wobbling and they have agency and everyone's got agency, but they're able to access it. And some people maybe need a little bit of support, like a managed equilibrium, just a little bit of support to keep them right. And it's really important to acknowledge this method isn't just for the most acute. Just to drill down a bit, we didn't start with this diagram, we ended up with it. So when we looked at all our cases, a few hundred of them over 5 different prototypes over 7 years, what we noticed is that the distribution of input into people whose lives were turned around started off with a combination of mostly high support, but then a bit of high challenge. That's the whole agreed purpose thing. It's not us knowing what the purpose should be and challenging. It's about saying, well, we agreed this purpose, but you're starting to do something that's not congruent with that. What's going on there? And then what happens is people's agency starts to become activated. But what's beautiful, and we didn't design for this, we just observed it, is when people start to take control over their lives, they start to want to help other people. We don't tell them to. It's not, we're not paternalistic. And it's a pattern, it's observable. So Brian ended up chairing AA meetings. I mean, the idea of getting him to one seemed incredible, and there he was chairing them. He now helps a university professor teach medical students how to engage with people struggling with alcohol. It's incredible. So, what do we think is happening? What's accounting for those loops? I think what's accounting for those loops is that when people present to a specialist, we look for their presentational acuity. I'm a mental health clinician. I'm going to look at how bad your mental health is if you turn up at my place. And we deploy a commensurate amount of specialist expertise and resources. But what we were noticing is that people turning up with similar degrees of presentational acuity, whether it's mental health or physical health or anything, we're getting very different outcomes. Why is that? Well, we all know why. It's because that's not the only show in town. But if we take a reductionist approach to public services, we think it is. What we coined was this notion of contextual acuity. What else is going on in my life? And what methods do I need to help me solve these problems? So what we found was that the Liberated Method was very good on the contextual acuity, and we needed specialist resources. And when we looked at cohorts of high consumers in different settings, what we noticed is that different methods were variously applicable, but we were tending not to apply the right ones. So we found that when people have got a low contextual acuity, that is that their life is fairly stable. They've got a support network, there's some resources, but they have a high degree of presentational acuity. The predominantly specialist intervention, the navigation, is sufficient. It does work for them. But if we have somebody and we mutually understand them and they understand what we're about, we will know that that's the thing to do. But that's what the system defaults to. But it doesn't work so well for people with high degrees of contextual acuity. So where you've got high presentational acuity, I'm really ill, I'm really struggling, I'm really scared, whatever it might be, and there's just a high degree of a specific thing. You need a bit of a hybrid of a liberated method with a specialist input in that caseworking cohort. So what this allows us to do, the challenge then, is to optimize that specialist intervention rather than to minimize it or maximize it. It's about the specialist doing the thing that only they can do at the time it needs to be done. And then there's another group of people who don't have a high degree of presentational acuity, but they turn up anyway. And why do they turn up anyway? Because they have a high degree of contextual acuity. If you go to the emergency room on a Thursday night, you'll see a lot of people who are fairly old, who are lonely, who are a little bit ill, and they're in a trauma environment. Why are they there? Because the lights are on and they're not on anywhere else. So they'll go there ostensibly not feeling great. They'll triage fairly low because they're not terribly ill. And because there is a target in the accident and emergency thing about medical assessment and admission or discharge within 4 hours, there will be triage low. So 3 hours, 55 minutes comes along. There's a performance indicator saying 4 hours, 4 hours. So what do you suppose happens to them? They haven't been seen by a clinician. They get admitted. Then they're off their legs, aren't they? And then their mobility starts to decline, and there's a white coat syndrome thing going on. And then when they need to be discharged, they're discharged with a package of care into the social care system, which they never needed, which loads the social care system up. Now, if we understand the notion of the difference between specialist and presentational acuity and the contextual acuity, if we understand that at the point of presentation, we won't admit people like that. We'll help them in where they are. We'll meet them where they are rather than bring them to where we are. So that understanding the demand, the type and frequency of demand through this lens fundamentally changes the public service proposition, and it's not how it's designed in the UK. Now, I'm not right. Don't panic. I'm not going to go through all the little bits on here, but it's an important point because as well as asking what's going on, I, we asked why. Why is it so difficult to do what feels so intuitively helpful? The turnarounds we achieved were achieved by mostly non-specialist input and pulling on specialists with context. It's intuitive. So why is it so hard? We studied all of that consumption of all those clients and we looked at the way they interacted with the system. The system calls them clients. For a start, we don't, citizens, people, humans. And what we noticed, we looked at all the policies that were at play, the eligibility policies and the progression and referral um, policies and all the rules. And we asked ourselves, what are the logics at play? And because if you know what they are, you can attack them. And we noticed there were a lot of different logics, but they were nested. And some logic drove other logics. So you have scale logics, which are if we do the same thing to lots of people, it'll be efficient and cheaper, won't it? Well, no, because it's one size fits few. And we asked, well, what's that a product of? What's that a product of? And the whole thing amassed into a single superordinate driver, which was to create and maintain a defensible position. And if that's the de facto purpose of public services, you end up with all those orange boxes. These orange boxes and the other orange boxes. You can tell I like orange. I've only just realised that they're the same colour. It's obviously a subliminal thing. Anyway, that's key because we need to work on what the different driver is. So, hang on. I'm going to run through to the next slide because this is more important. We recognized that the drivers were key, so we changed them for our prototypes. So the superordinate driver is help me to thrive. And how do we do that? Well, we need leadership that understands that we need to act on the system, but we need to build learning in. We need to be focused on effectiveness, sorry, because the system was only obsessed with efficiency and with eligibility. We need to understand what matters. We need to understand context, and we need to work collaboratively as if it's one system, because that's not how it works. I'm not going to go through all this either, but these were the emerging logics when we did the debriefs with all the caseworkers. This is what was playing out. And it was really helpful because it's just so different and yet so possible. Again, I'll whip through because I'm conscious of time. So we've looked at the what from a person's point of view, from a cohort's point of view, from a systems point of view. We've looked at the why from similar points of views. So then another question really leaps out of this analysis, which is, well, why isn't this normal now if it's so easy, Mark? Come on, what's going on here? And this is where our academic colleagues were helpful. They noticed that there was an internal consistency to the existing system that made it really hard to destroy, if you like, or beat. And we were doing it because we were creating an artificial environment where we could be internally consistent but different. This is important if we're going to make it normal. No point in doing prototypes forever. I don't want to do any more prototypes. I want to make a system like this. So what are we up against? Key thing about this piece of work and any prototype is there's two real things to focus on. The first is what I've mostly talked about so far, which is how do we do it better? But the other thing to do is, as the director, I'm holding the system off. So in holding the system off, you become aware of what the system is trying to get you to do or is objecting to. So note that. What is it that the system doesn't like? Because that's your clues as to how to make it normal. And what we found is there were 5 things that were getting in the way. So they had a financial stalemate across the whole system, which meant that if Service A invested a bit more than perhaps it would be minded to, Service B would save a huge amount of money, but the money that they save wouldn't flow back. So why would I bother? I'm just going to focus on my own internal efficiencies instead. So nobody blinks first when everyone gets around the table. It's actually, if it wasn't so drastic, it would be funny at the workarounds people would put in to keep all their own money. The way we do change is critical. It's very standardized and it stops us doing from nuance to allowing nuance to contribute to outcomes. We've had what's called austerity in the UK for the last 14 years, where the government has just cut, 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 cut. And it hasn't just reduced the amount of resources, it's taken a focus away from efficacy and onto efficiency. And doing the wrong thing right ain't going to help. The way we do leadership is based on maintaining a defensible position. That needs to change. Commissioning, I don't know if that translates over to the US, but commissioning is this idea that somebody in a room will determine what good looks like and will put that out to the market. Suppliers will bid for that, and then they'll be managed on cost and on compliance. So it's a preemptive version of the solution. It doesn't allow iteration. So you'll only do what you've been commissioned to do. No one's commissioned to do poetry, dog grooming, carpentry, blah, and all the things that got Brian out of that hole. And then the way we use our measures is to service contracts or to service a regulator or an inspector. We don't really know how good we are at stuff. We just know how busy we are and how much it costs. We're really good at saying how busy we are. Well done us. Okay, so the analogy we would use is we often any Harry Potter fans here, we often refer to them as the Horcruxes. You need to get them all. Now, loads of prototypes have got one or two of them, but if you haven't got them all, the system will not change. Even if you've got four of them, the fifth one will come and bite you, and you're back to where you were. It's Horcrux time. And a lock is another good analogy. All those levers need to move, otherwise it ain't opening. Okay, I'll be quick now. So this is the final slide, I think. So just to summarize, we know that navigation isn't as effective as relationships. The only exception are for those people with low contextual acuity and high presentational acuity, but the system's already good at that. What we need to really focus on is this obsession with navigation. We know contextual acuity and context in general is the gold here. Specialisms have become so prized because they're hard won. You know, you go to university for 7 years to become a doctor, you'd be forgiven for thinking that the answers are all there. So somebody with no qualifications but understands that family comes along with a nugget, you take it less seriously, and you do so at your peril. Doing better things versus doing things better. This is the key. We don't want to just do things better. We've got to do better things. This is how we do change and how we measure our own learning and development. So a distinction between those two mindsets is really important. And the internal consistency piece is key. It's the why, not just the what. And I think that's me. So I'll end it there. Thank you.
Looks like you are receiving wild rounds of applause, Mark. Thank you so much.
Really?
That's amazing. I could stare at those charts, I think, for hours. Like, they are fascinating, and I love how you kind of showed that story through an insane amount of tiny orange boxes. So thank you. I really
welcome.
appreciate that. So I am sure we are going to have some questions from our audience. Y'all are welcome to drop your questions in the chat, and I can call you out or read them out for you, or you can raise your hand if you'd like to ask your questions audibly. I'm not sure exactly what the word is.
I'll jump in.
Wonderful.
Hi, Mark. My name is Catherine Casillas. I'm at the University of Colorado at the Kemp Center for the Prevention and Treatment of Child Abuse and Neglect. I sit among many colleagues who work in child welfare, support the child welfare workforce, although my work sits more in early childhood. And we're often having this conversation, right, of changing the system, or the system's not working. I really appreciate and won't repeat everything you said, right? It's multiple systems and a little bit of a conundrum, right? That we want them to work better. We know some of those supports are still needed, yet the answer lies outside. So loved the work that you're doing. And so I guess my question is, where does that person sit? Is this, how did that person come about, that navigator? How do they work across the systems? Just more of the hands-on, like, how did you get to that point? It's fascinating, and I'd love to hear more about the boots on the ground, I guess, that the navigator kind of piece of it and their place. Where are they?
Yeah, well, okay. You're referring to the worker or the citizen? Are you asking where the worker is in all of this?
A worker who's just
Yeah,
thinking about
okay.
that need that might lie outside of the system. It's a wonderful wonderful work.
because the system isn't very capable of low caseload generalists, anybody who has a caseload tends to have a high one, and it tends to be based on your thing. So social workers have really high caseloads, and it's really hard for them. So we needed to manufacture that out of nothing. So what we made a point of going around lots of, so our staff are from multiple organisations. I work for the local authority, but we have people from voluntary sector organisations, from the health system, and they've all got one thing in common. Can I mildly swear? Will people be hugely offended?
Yes.
We wanted people that were pissed off for all the right reasons. Because the recalcitrant people who were trying to do that right thing are the ones we needed in this prototype. We needed those early adopters that were dissonant and fed up. They couldn't quite put the finger on what was broken, but they knew it was. And one of the things that we wanted to do is create an environment that was artificial, but we could work on the what. So we created a specific project for them, but now that's evolving. So what we're finding, so if you take the council tax thing where I started, they have a team of people that deal with this. So the point of this is it's a method. It's not a service. This could go anywhere, and it's fairly structurally agnostic. And that word agnostic is important because not only is it the role structurally agnostic, but one piece of analysis that I didn't share, which perhaps I'll do now, is that if we study the amount of work that the guys do and you count the tasks, about 60% of what they do is structurally agnostic. That is, it's that stuff the specialists would never do. So no amount of system change gets anywhere near that 60% of work by count. So yeah, they could sit anywhere, Catherine, but I think for us, they sat in a specific prototype and now they're finding their way into existing structures. So we haven't really needed to do much of a structure change because you can make any structure work with a good method.
Thank you, Mark. We'll go over to Gwen now. Feel free to unmute.
Hi, Mark. Hey, everybody. Thank you for sharing this amazing body of work that you're doing. I too am in child welfare, so I'm at the Kemp Center as well. And our, the work that I've been doing and thinking about is actually how do we not even get to the system? And I've been really curious about, sort of the upstream, downstream. It's sort of like when we get downstream and we're having to just pull babies out of the water, the costs are very, very high at that point. And it's how do we get upstream and even because the minute they enter that system, we're in trouble.
Absolutely.
And so I'd love to hear your thoughts about also how you're thinking upstream.
We've done some work on this. So there's a study by Professor Sir Michael Marmot who looked at what he referred to as the determinants of health and well-being.
Yep.
And we were able to see that in Gateshead, where I work, there was a particularly pertinent example of two streets 200 meters apart where life expectancy was 10 years different.
Yep.
So if we know that when these children are born, why don't we act like we know that? And what does acting like we know that look like? We've adopted this approach. It's slow going, and one of the reasons it's slow going is because when you work with the determinants of health and well-being, you don't see the results. There's the counterfactuals get really complicated, and it becomes a difficult thing to prove. But that's based on an idea that we have to prove it. Why don't we? The research already shows that it does it. So we're working on the determinants of health and well-being because we know that longitudinally that's going to play out. That's a different piece of work to this one, but the study of the history of the people in this work was exactly the same as what Michael Marmot showed us. There is a specific example of that where we go upstream, but not as upstream as that. So in the homelessness work that we did, we noticed that a decent proportion of the people that were homeless that we were working with were previously in the social care system as children, and specifically within the Gateshead social care system. And when they left the child social care system in a state of chaos, 80% of them were homeless within 5 years.
Yep.
So now we know when people are at that position in the social care cycle, we know that there is a specific signal there. So the way that people are segued out of that system has changed. So that's not miles upstream, but it's a bit upstream.
Yep.
So there's a bit of work that we're trying to do the let's not get them into the system stuff. The voluntary and community sector are better at that than we are.
Yeah.
And we're trying to go a bit upstream to people that are wobbling as well. It's a work in progress, and we have by no means cracked it, but it is something that's on our minds, because I don't want to keep having to do this all the time.
Right, right. Thank you.
All right, we're going to move into the chat now, and then we'll come back to folks with hands. So Connie asked, is the analysis shared an offshoot of lean management or another patient-centered method? I'm curious about what resources helped you create this understanding of patient experiences.
It's not knowingly an offshoot of lean. There are some similarities with the Vanguard method and some of the systems thinking stuff, but that is predicated on the idea that the system is 95% responsible for performance, a la W. Edwards Deming. What we know is that if the context is rich in the value work, that relationship breaks down. So it's not really an offshoot of that, but there are similarities. In terms of the resources, everybody needs a Ron. Now, let me tell you about Ron. Ron is a retired detective police inspector. He was a retired cop. And when we were trying to do this analysis, I had an analyst in and he just didn't know where to look. And I realized I didn't need an analyst, I needed a detective. So I hired one. And he went everywhere. Absolutely everywhere. Those orange boxes are Ron's work. They're not mine. So the resources that helped us create that understanding of patients' experiences is Ron talking to people, showing the caseworkers how to elicit those what's the phrase I'm looking for? Ethnographic sort of approaches. And to use that to guide us into the data, we had to get data sharing agreements to allow us to do it. And then Ron used Lucid Chart and put it all on there. And we were able to tell that story. So it's a bespoke analysis, really. We've had to kind of wing it, just try and represent our learning the best way we can. But I can see some overlaps with the lean stuff. I have done that in my career, but there are some significant differences, particularly around the role of context.
Thank you, Mark. One more question in the chat, which does kind of relate to data as well. Kathy is asking, when doing the relational work, how does your data collection change to verify outcomes?
Oh, this could be another hour. So one of the things we got wrong at the very beginning of the Changing Futures work is we had a learning team whose job it was to synthesize all of the casework, all of the journals, so that the caseworkers all journal. We asked them to do that. And then we have team review every week where we discuss the journals and we look for patterns. And then we have a bit of software that helps us look for patterns as well. And then we try to sense make the theory. And what's emerged, what we found is that the data team, if you like, it was an extractive process. So it was an adjunct to the casework, and that's wrong because immediately you're biasing it. So we had to train the caseworkers how to journal their reflections as well as the reality, because they're important too, and to talk about what happened. And what we did is we created a series of 4 interconnected learning loops. One around practice, and that's essentially creates conversationally contextual learning, which we test. So next time we get one of these, why don't we try that? It also creates a loop around teams and structures. One of the questions that we ask in those reviews is what made it easy to do a good job, what made it difficult to do a good job. Synthesize that. Okay, the route to get a wheelchair for somebody takes 6 weeks, 5 forms to fill in, and they never say no. So why don't we just get one straight away? So that piece of analysis helps us to just debunk a process. The third loop is around system drivers. Okay, we have an eligibility criteria here, it's predicated on scarcity, but actually it drives demand up. So we assimilate the data, and all of this happens in case review. And then the fourth loop is theory, how we see the world. And that's how we arrived at the high support, high challenge, active agency, helping others diagram. That came out of an analysis of the work. It grew out of the learning loops. So our colleagues in the academic sector, particularly Professor Hannah Hessel-Greaves, who's now at Manchester University, really helped us to develop some rigor around that. And what was a joy for me is we had academics and caseworkers in lockstep trying to develop theory, method, and practice. It was joyful, and it took away the hierarchy of evidence and turned it into a hierarchy of depth. And it was probably at least the joint most rewarding part of this work. And Hannah coined a phrase which stays with me. And she said this work enabled her to prove that a focus on learning was more productive than a focus on productivity. How cool is that?
It's so cool.
I
Everything
get
you're
excited,
doing
Sharon.
is so
So sorry
cool.
about this stuff. I get excited. I'm sorry. It's
No,
Friday night. I should
do
be. I
not
should.
apologize. Peter, it looks like your question was answered by that, but feel free to jump in after this if it was not. So we'll go to Glenn.
Okay, so I am a physician, so this will come from the usual physician, narcissistic, somebody else solved the problem kind of deal. So what I'm hearing, and I'm not even sure this is for Mark as much as maybe the entire team, is I'm hearing three things, three major components. One, Mark actually did something. So therefore, he created action, which we can't seem to really do. So maybe offline, Mark can help whoever the powers that be, Sarah can take charge, to figure out how to actually take action. So that's number one, action. Two, goes back to both what the whole Kemp Center team was talking about versus the sustainability. So the step that we can do, though I don't know who's going to do it, and somebody has to step up and take action, is the sustainability is easy in the sense that that high risk, high cost individual or family shows that it pays for itself within 2 years, at least in
Yeah.
Mark's
Yeah.
graphs. So we have to create a pro forma that says somebody it's going to pay for itself. Then the Kemp Center people hit the third thing, which is critical, is then how do we even prevent that from even creating that $2 million dynamic, which in the US is we would need an act of God to make that happen because we'll never show a saved dollar because that's
Yeah.
too far down the line and we'll
Yeah.
have to show the saved dollar. So the person, it's kind of like the entire healthcare system. We will only do something when the person fails, as opposed to preventing the failure to begin with.
Yeah.
So I think this is all brilliant, but somewhere, somebody within our team, maybe with Mark's guidance, and maybe the question is who in our team takes that leadership role that steps outside the box and is willing to risk, because otherwise this amazing presentation by an amazing human being will go to waste.
Gosh. Thank you. I mean, I'm just sorry. I'm just reeling from that. We do have a similar problem here that there are people saying, yeah, but where are the savings? Where are the savings? Where are the savings? And we can show cost avoidance, which is not quite the same as a saving. But what we can also show is that there is an unmeasurable but very definite knock-on effect, which is if that person isn't offending anymore, there's far fewer victims of crime. If that and on it goes. So there are health economists that are trying to work out the multiplier, the ripples here. And whilst that might be quite an engaging process, I do think it risks, and I am for it. I think that should be done. But what I don't want to do is I don't want to back that horse solely. I think the key for me is about saying, but why are we doing this? What's our purpose? If it's to help people have the relationship they need to thrive and it's doing that, then that's good. The orange boxes show us, and this is the analysis I think that's really helping me. I've been fighting the battle that Glenn referred to, which is, yeah, but where are the savings? And they are a long way down the line. It's not this, even though the health system over here is different, it still has that problem. But the way I flipped it, and I made a few enemies here in finance departments in hospitals, was to say, show me the business case for carrying on as you are. Because this suggests there isn't one. So if they're going to throw the whole business case, weaponized business cases, well, back at you. So that's been quite a helpful, slightly provocative discourse. But it has genuinely raised the question, well, if there's no business case carrying as we are, we may as well start to look at other things which are congruent with our purpose, not just cost. So we've developed a measures framework, and it essentially has 4 domains to it, which is the extent of impact, the extent of what we call persistence. Does it work, but does it stick? No point in something working if it doesn't stick. Can it grow? and how does it make people feel when they're doing the work? Because if you know all four of those things, your business case argument starts to fall away, and your why are we doing this in the first place argument starts to take over. I've got quite some way to go with that. I have to tell you, I'm sounding more confident than I feel about that, but it is making some headway in some areas. So the next challenge for us is the normalization and proliferation piece, because we know we've got a good method. So yeah, long way to go.
Great question, Glenn. And Kira and I have been
Mm.
meeting with Mark for the past 6 to 8 months and some folks with CCTSI to try to answer that very question and find some funding to just have Mark come over and fix our entire US healthcare system full time for us. So Mark, if you could just clear up the next, 5 to 10 years of your schedule, that would be great.
Good. We're off to Colorado.
I'll pass it over to Cheryl for a question that she also had in the chat, I think, too.
Yeah, thank you. Actually, and I feel like Peter already pretty much asked that same question, and Mark, you kind of already really answered it to begin with. But I think because I want to just comment on it, I keep going back to the way things work here in the United States, and I sometimes question, and I don't want to sound cynical, but I kind of question, are we doing, not we, but is like the healthcare system a space in which they're trying to make people healthier, or is it just a business where that's really kind of what it's about? And like, and what that might be what prevents activity that needs to happen or change that needs to happen. This would be kind of letting go of that income flow and the fact that we're not being able to save them money, or I should not say the money, but not being able to make them money. That to me seems like, why would they do that if it takes away from their business? I just wanted to make that comment.
Yeah, sure. I think you're absolutely right, and I think one of the Horcruxes I described was the financial stalemate. Now, the manifestation of that will be different in the US than it is in the UK, but the spirit of it is precisely the same, which is the idea that the de facto purpose will take over if you don't have a transcendent one. So that messy diagram with all the drivers on it, one of the things in the top right of it, if I remember, was a little list of the de facto purposes from all the different bits of the system. So in the UK, because it's not an insurance-based health system, but it is a really weird old-fashioned new public management version of health, the de facto purpose of a hospital is to get people medically fit and get them out. It doesn't have a system-wide contribution to make in terms of its purpose, even though it clearly does in terms of the people that work in hospitals who really care about people. So, you've got amazing clinicians and amazing support staff and an amazing network of fantastic humans working to a really weird, screwy purpose. But the purpose of a school isn't what you might think it is. It's a de facto purpose, which is beat the school down the road. So it becomes really skewed. So when you've got multiple de facto purposes working against each other, the transcendent one barely stands a chance. What we're trying to say to government is only you can resolve this. So that's why we can only do so much locally. I don't think it's cynical at all. I do think these de facto purposes can be really survival based rather than altruistic or community based. That's the nature of this complex adaptive system that we're in. And it makes it really hard. It's why it's my life's work. It's just, but I do think the recent stuff is showing that it's possible. But by God, there's a lot to do.
I think we could probably stay on this topic for the next, year, as Mark said, in the exact same Zoom room. I did share in the chat some fantastic resources that Mark has previously shared with us that kind of go into detail and on his work more and review some of what we talked about today. I'll also be recording, this meeting was recorded, and I'll be uploading it to our YouTube and sending out to our entire coalition. So I encourage you all to share this with folks that weren't able to make it today, but still could really benefit from the information. And then if you'd like to connect with Kira or I in more detail to kind of talk about where we can take this work next in Colorado, please don't hesitate to reach out. I'll drop my email in the chat once more before we head out, and we can get that scheduled probably for the coming year, since it's already December somehow. I don't know where this year went. But truly, thank you, Mark, so much for coming to share with us.
You're
Thank you
welcome.
for staying late at 5 o'clock and working with us from the UK. We are so grateful to have you and grateful for the work that you're doing.
Thank you. Really pleasure to meet you all, and have a really great weekend. Have a great rest of Friday for you, and I'll have a great, not very much left of Friday, hopefully.
You have a great weekend. All right,
Thank
take care,
you.
everyone.
Okay, thank you, everyone.